Good afternoon, everyone. A great pleasure for me to be here. And first of all, I would like to thank Canon. I say myself, please, Carlo, don't forget, not Toshiba, Canon, and for kindly inviting me, to present a short talk about new advancement in the ultrasound evaluation of rotator cuff tendons. And you know, at ECR 2019, we are in an aquarium, and you see some fishes at the beginning. But now we move to humans, and as you know, the rotator cuff is a very complex structure involving 4 flat tendons, the subscapularis, as you know, the supraspinatus, the infraspinatus, and the teres minor, visible here on the posterior aspect of the shoulder, plus the long head of the biceps. And things seems to be simple, no? Oh yeah, 4 tendons plus 1, no? But things are much more complex than expected. This is what is the appearance of the rotator cuff as we can imagine when we perform an ultrasound examination. We have the arrangement of the tendons, the subscapularis, the supraspinatus, the infraspinatus, the fibers of the 2 tendons, as you well know, are interwoven, and they form a continuum here, the cuff, no? In which is not easy to demonstrate how the 2 tendons merge with each other. Then we have the interval, and the interval is also a very complex area because it's occupied by the long head of the biceps, but you know that at the level of the interval, the long head is stabilized by some ligaments, no? The coracohumeral and the superior glenohumeral ligament, and these ligaments form a sling around the biceps here. But nothing more, no? For us, this is the main structure of the cuff, no? At least going to scan the cuff with the ultrasound, and we didn't ask ourselves more in terms of structural anatomy of this area. But this is a very simplified structure. Basically, we have other relevant structure that can be potentially visible with ultrasound. So this is a drawing of the shoulder showing the glenoid in the center, the origin of the biceps here. You see the subscapularis anteriorly, the coracoid, the acromion, the supraspinatus, infraspinatus, teres minor here, and this is what we know until now with ultrasound. But there is more, because there is the capsule. Are you able to demonstrate the capsule? There are some ligaments. You know, we mentioned the superior glenohumeral, but we also have the middle glenohumeral, we have the inferior glenohumeral, and the inferior glenohumeral is characterized by an anterior and a posterior limb, and we also have a spiral part on the anterior aspects of the joint. So it's anatomically complex, this area. We need to realize that what we see is not just one tendon, but is the sum of the tendon with the other structures at the same level, potentially joint structure, capsular structure reinforced by ligaments, by specific ligaments. And this is more or less the same image, so the same drawing as it appears in reality. We see the origin of the long head here. This is the capsule on the undersurface of the 2 tendons, 2 external rotators, so the infraspinatus and the teres minor. Anteriorly, we can see the position of the subscapularis. We also have the subscapularis recess here, the coracoid, the conjoint tendon of the short head of the biceps and coracobrachialis. But when we look at the capsule, we also see some linear structure referred to the glenohumeral ligament, specifically the inferior glenohumeral ligament. And this is a cranial view showing the position of the axillary pouch, the position of the bands of the inferior glenohumeral ligament. And for us, the question is, can the glenohumeral capsular complex be distinguished from the overlying tendons? In this field, the introduction of matrix probe technology and of very high frequencies, probes with a frequency band higher than 20 megahertz, can provide new details about the cuff. The capsule is actually visible when we don't have tendons. No? So, you know, when we go to scan the axillary recess, the axillary pouch, and we ask the patient to hyperabduct the arm, this is what we see. We see the convexity of the humeral head, the articular cartilage, and the bright area you see here is the capsule. Inferiorly, the capsule is visible. And even if it's impossible to have hyperabduction, when you select an anterior approach to check the capsule, in cases of adhesive capsulitis, you can see some changes of the capsule. So this is a normal capsule on the non-affected side of a patient with adhesive capsulitis, and this is the capsule as it appeared at the level of the axillary recess of the joint on the affected side. You see a big difference in terms of thickness, and these kind of images may increase your confidence that this condition is present, so they may contribute to the diagnosis. Now I would like to show the capsule at the level of the axillary pouch. Shirt off. Please lie down. And this is an area where the capsule is actually well exposed. We place the probe here. We see the inferior part of the glenoid. So the inferior labrum, and this whitish line here is the capsular line. So it's really easy to see at that level because we don't have a tendon, especially the capsule is not included in the structure of a tendon. But may I have the PowerPoint slide, please? When we scan the subscapularis, for instance, on the anterior aspect of the shoulder, we note something that is not really recognized yet. So look at the tendon. This is the subscapularis. This is the myotendinous junction. So this is the subscapularis muscle. And in a more medial position, you can see the short head of the biceps here. You see the coracobrachialis. More superficially, you see the deltoid here. And this is the humeral head. Look at the tendon of the subscapularis. The tendon of the subscapularis is characterized by a fibrillar area, visible here. And you see that the upper fibers, the most superficial fibers, are fibrillar. And then you can follow this part more medially, and you can realize that these fibers pass on the undersurface of the myotendinous junction. So the myotendinous junction is eccentric in this case. But what is that? Is tendon? No. This is the capsule. So what is believed? So when we scan the subscapulary, we believe that all the thickness of the tendon is tendon, but it's not true. The tendon is very thin, and the structure located here is related to the capsule. So it's bilayered. There is a bilayered structure with a superficial fibrillar part and a deep non-fibrillar part. No? And this is another image showing the two parts going more medially here. You can understand that there is a cleavage plane. When you move the shoulder with a slight internal and external rotation, you can also see the two parts as they glide with each other. So they are not stable. They are not intermingled. They are lying one superficial, one deep, but they are separate structures. So remember this point. Where can we see this bilayered structure in the subscapularis? Not really when we go to scan the most cranial third of the tendon, it looks fibrillar for the most. But when you go down and you scan the middle and inferior third, this image becomes nicely visible and reflects the fact that at the level of the inferior part of the subscapularis, the capsule is thicker. So now I would like to scan the subscapularis, but before going to scan, remember this position to image the anterior labrum. No? To do that, we invite the patient in general to lie down on the bed with the arm abducted, as you can see here. And again, here we can see two layers, one superficial and one deep. The superficial layers continues within the muscle belly, as you know here, and this is the myotendinous junction of the subscapularis. This is the subscapularis muscle, but the other layers goes more deeply, and it reaches the tip of the anterior labrum. So this is not the tendon. This is the capsule. Okay, because there is no connection between this layer and the overlying muscle here. So do you remember the image of the capsule at the level of the inferior aspect of the shoulder? It's very similar, but in this case, we have the subscapularis covering the area. So now I would like to show the subscapularis tendon, inviting our model to lie down here, to place the arm in this position. And then we place the probe here. The frequency is now not very high because we decided to select lower frequencies to better demonstrate the deep details. And we see the convexity of the humeral head here. This is the cartilage. This is the anterior labrum, nicely depicted here in this position. And this is the anterior glenoid. No? When we go towards the lesser tuberosity, so in this area, we realize that the tendon is formed by the tendon. What was believed to be the tendon is characterized by a fibrillar structure located superficially and a non-fibrillar, homogeneously hyperechogenic area visible here. When we follow the fibrillar layer more medially within the belly of the subscapularis, we see the myotendinous junction. This is the intramuscular tendon. And you know that the subscapularis is a multipennate structure. So we'll see more than one of these images depending on the level of the probe. But when we refer to the deep layer, we see that it continues down and it attaches to this area in a relationship with the labrum. So now I try to change the degree of abduction. I rotate the shoulder externally and internally, and I see this kind of image, and I realized that this cannot be part of the subscapularis. You see? It's located outside the muscle, and it continues with the anterior aspect of the joint. So this is basically capsule, is the anterior capsule of the joint. So may I have the slide, please? Okay. So this is what we saw before. This is the anterior labrum, and this is a short axis image of the subscapularis muscle. And you see the multipennate structures with the intramuscular tendons. You see multiple intermuscular tendons here, and the deep to them, this is the capsular level. So when we refer to a arthro MRI, you can realize that what is really the intramuscular part of the intramuscular tendon of the subscapularis, they run in the middle of the muscle and far away from the deepest part of it. No, so the hyperechogenic part doesn't represent the intramuscular tendon of the subscapularis. It reflects the joint capsule. To be sure, we injected some dye in a cadaver, just in the interspace between the two layers, and this was the result. You see, the subscapularis was displaced by the anatomist in this image. Deep to this area, we have the humeral head, and you see the multipennate structure. Here, these are the intramuscular tendon of the subscapularis, and this is capsule, and the dye accumulated in between these two structures. So they are really separated, especially not close to the insertion of the subscapularis, but in a more medial position. So look at this image. This is a nice anatomic image showing the glenoid here. You see the lesser tuberosity. You see the long head of the biceps here. You see the transverse humeral ligament stabilizing the biceps. And this should be the origin of the subscapularis, the insertion of the subscapularis. But here you see the same arrangement with one superficial part related to the tendinous layers and a deep part continuing with the glenoid here. And this is the capsular layer. So it's incredible but true. Now, what the eye don't perceive what they are not prepared to see. For 20 years, I scanned the subscapularis without asking myself what is the tendon, where is the capsule. And now, with the use of these very high-frequency matrix transducers, the difference is very clear. So remember, in terms of anatomical insertion of the capsule into the humerus, remember that when we refer to the anterior aspect of the humerus, the area we scanned before, we have a cartilage-invested part here. Then we have a thin areas not covered with cartilage and without any kind of capsular insertion. This is a bare bone, and this is the typical location where we can identify some erosions in chronic inflammatory disorders. And then the red line you see here represented the width of the capsular attachment into the humerus. The width of these attachment varies depending on the level, as you can see here, and is much wider in the areas where there is no overlap with the rotator cuff tendons. So the capsule attaches for a longer, for a bigger area of the humerus here for a smaller area where we have the subscapularis. These are the values indicating the areas of capsular attachment, and you realize that at the level of the axillary pouch, the attachment is wider than at the level of the subscapularis. In terms of thickness, there is a nice paper published this year in the literature using micro-CT to demonstrate the capsular thickening. So there was, the authors dissected the capsule and then tried to calculate the thickness of the capsule using micro-CT. And if you refer to this piece of capsule like a necklace, no, around the humeral head, you realize that at the upper edge of the subscapularis, the thickness is lower. The lower edge is much more. There is a big thickness also at the level of the axillary recess, and then moving up from to the posterior aspect of the shoulder, we have a thin capsule at the level of the teres minor, and the capsule tends to thicken at the level of the infraspinatus. So there is a variable appearance of the capsule. This is a patient with a shoulder instability, no? Same image as shown before. The patient have some episode of anterior-inferior shoulder dislocation. Look at the capsule. So is ultrasound able to distinguish the glenohumeral ligaments from the capsule? The answer is no. Possibly when there is some distension of the joint cavity, you can see some focal areas in which the capsule may appear a bit thicker, and this may reflect the position of a glenohumeral ligament. But we have to consider the echogenic area we demonstrated before in our model as some of the capsule reinforced by ligaments. So this is the first concept. Now we move up to Oh, no, I use this position to demonstrate the anterior labrum, because you can force abduction and you expose much better. So the quality of the image when you use this position it's higher to demonstrate a deep-seated structure, and especially anteriorly, where you have the anterior labrum. Did you see the anterior? If we could you switch to the ultrasound image, please? So this is a nice image, no? If you perform the same in this position, the result you can see, but the result is not as good as when the patient lie down. So this is my suggestion. Now we go back to the slides, and we move to the area of the supraspinatus. No? One of the typical questions, the most asked question is, where is the limit of the supraspinatus and infraspinatus? Is there a way to understand the separation plane between supraspinatus and infraspinatus? So you know that the two tendons are interwoven. So part of the fibers of the supraspinatus moves posteriorly, and they merge with the fibers of the infraspinatus. Okay, this is known, no? And this is the concept of the cuff. When we place the probe in the long axis of this tendon, in general the tendon is non-fibrillar, and this is due to the fact that the fibers have an oblique course. No, are interwoven, and so in the supraspinatus the tendon is not as fibrillar as the subscapularis or the infraspinatus or other tendons in the body, with the exception of one area located anteriorly at the level of the anterior third. We have a cylindrical bundle of fibers going parallel with each other. This cylindrical bundle is located superficially in the tendon, not deeply here. And the characteristics of this bundle is that it feels an anisotropy, because fibers are parallel with each other, no? They are not interwoven. So when we check the supraspinatus and we see this kind of image, we see some fibrillar architecture. And this is called the pseudobiceps, because it's very similar to the biceps. The bicep is very close to the anterior third of the supraspinatus, so one has to be careful to avoid any confusion, no, in distinguishing these two parts. And these two parts correspond to what you see on anatomy, no? You see the cylindrical bundle here, and then the flattened tendon of the supraspinatus going, expanding also posteriorly to form the cuff. In addition, we have the coracohumeral ligament. We already discussed the coracohumeral ligament, and we see the ligament as a bridge joining the supraspinatus and the subscapularis, and also inserting at the level of the tuberosities, forming the roof, no, of the long head of the biceps. More distally, we have the attachment of the superior glenohumeral ligament to the complex of the coracohumeral ligament, and this link is named the reflection pulley. As you know, the reflection pulley is a structure stabilizing the bicep in its proper location, and it's very important to give stability to the tendon. But it's not really clear what happens posteriorly. So if this is the position of the long head of the biceps, the coracohumeral ligament covers the biceps, forming the roof at the level of the interval. And then remember that part of the fibers of the coracohumeral continues superficially to merge with the supraspinatus here. Other fibers pass on the undersurface of the supraspinatus. They join with the capsule. And you can see these fibers very nicely, approximately 1 centimeter medial to the level of the tendon insertion at the level of the rotator cable. No? So when we refer to this area and we continue on our exploration posteriorly, we realize that the tendon of this supraspinatus, together with the coracohumeral ligament and together with the capsule, because the capsule is located here, remember that the biceps is intracapsular in location. So the capsule passes over the biceps here, and then it moves here. It's the deepest structure located on the undersurface of the cuff. So capsule, coracohumeral ligament, rotator cable, and the fibers diverging from the infraspinatus form this kind of layer that is located deep to the tendon of the infraspinatus, no? And this kind of structure is named the superior complex. Look at this image. This image is obtained at the level of the junction between supra and infraspinatus. We are scanning not close to the insertion, but at the level of the myotendinous junction. So if this is the supraspinatus muscle, is the myotendinous junction of the supraspinatus, what you see here is in part tendon, supraspinatus tendon. In part it is the capsule, and in part it includes fibers coming from the coracohumeral ligament going posteriorly. So this kind of complex is named superior complex, no? And it includes all of these structure. Then, in a more superficial location, we have the infraspinatus tendon. So this is the structure. We have a deep layer, and this is the content of the deep layer. And then two separate structures, the supraspinatus and the infraspinatus, located superficial to the deep one. The deep one, of course, contains also fibers of the supraspinatus, but is not pure supraspinatus. No? So look at this image, you understand, no? That there is something enfolding on the undersurface of the infraspinatus. This is the infraspinatus tendon. This is not the infraspinatus tendon. This is the most posterior part of the superior complex. So this is what happens at the level of the interval. We see the biceps, we see the coracohumeral ligament, and now you can see part of the coracohumeral ligament going to embrace the anterior edge of the supraspinatus. This is the continuity of the coracohumeral ligament passing deeply to form the superior complex, and this image is commonly known. In some areas, it becomes fibrillar, and this happens at the level of the rotator cable. The rotator cable is a distant fibrillar structure traveling transversely from the supraspinatus and the infraspinatus. The cable is fibrillar when you place the probe in the short axis of the tendon, and its spatial ecotexture make it possible to distinguish it from other structures. So you know the role of the cable is very important for orthopedic surgeons because and its integrity in cases of injuries of the rotator cuff was associated with better with the better biomechanical preservation of the cuff, with a lower degree of retraction and lower pain. So this is the rotator cable continuing posteriorly together with the structure I described in the superior complex, and this is the tendon of the infraspinatus. This is a transverse image of the cable, as you can see there. So, but what is, now I would like to show this area with the high frequency probe. And we have to switch the probe to 24 now, because the supraspinatus is very superficial, so we can select a higher frequency transducer. And for us, when we scan the supraspinatus, we use the Middleton position, the modified CRAS. And we place the probe at the level of the biceps. No, the biceps is a very important landmark for us. No, the biceps is hyperechogenic and is very fibrillar. And this is the proximal part of the biceps at the level of its intra-articular portion. The biceps is here stabilized by the fibers of the coracohumeral ligament. This is the sling, the reflection pulley. So the fibers I see here are related to the superior glenohumeral ligament joining the coracohumeral ligament. And when I follow the coracohumeral ligament towards the supraspinatus, I see some of the fibers going superficially here, joining the anterior part of the tendon, and other fibers moves deeply at the level of the tendon body. So I understand that there is a superficial part of the tendon here and a deep part of the tendon. And if I go more proximally, I see that this deep part is no more hypoechoic, but it becomes fibrillar. And this is the position of the rotator cable. And the rotator cable is in continuity with the coracohumeral ligament here. So this is the cylindrical bundle of fibers I described before. No, please don't move. This is now is hypoechoic. Now it's look hyperechogenic. No, and then I go posteriorly. I see the myotendinous junction. I understand that the tendon is formed by a deep portion and a superficial portion. So this deep portion is the superior complex, including the capsule, the cable, the coracohumeral ligament, and the fibers of the supraspinatus, together with the other structure I mentioned before, continues posteriorly, and they pass on the undersurface of the tendon of the infraspinatus. So this is the tendon of the infraspinatus, and I see that some fibers are transversely oriented here, no? So they don't belong to the infraspinatus. The infraspinatus tendon is located more superficially at this level. This is the most posterior extension of the supraspinatus more or less enriched in the capsule and the coracohumeral ligament. So we move to the slides. When we go towards the insertion, another important point, remember that if you wanted to dissect, there is a nice paper published in 2007 on Journal of Shoulder and Elbow Surgery. They say that the supraspinatus and infraspinatus can be easily separated up to 14 to 26 millimeter from the most lateral point of their insertion. So this means that more distally, approaching the greater tuberosity, the structure becomes merged with each other, and it's difficult to separate them without creating a rupture at the level of the capsule. But when you look at the superior aspect of the greater tuberosity, this is the footprint of the insertion of the supraspinatus, infraspinatus, and teres minor. And remember that this is the red line visible here indicates the attachment of the capsule. We forgot that. So this is a lesser tuberosity. There is some bare bone at the level of the humeral sulcus, but not much. So it's interesting that some authors recently published a paper in 2019 about different pattern of tendon retraction in full thickness rotator-cuff tears, for which there was some delamination of the tendon structure, and in some cases this is what you can see. So the delamination and retraction of the deep part of the supraspinatus, probably reflecting the avulsion of the superior complex, whereas the superficial part of the two tendons converging towards the insertion remain unaffected. So, and there is also some discussion, about which perhaps the articular-sided rotator-cuff tears represent a damage of the superior complex rather than a pure rotator-cuff tendon tear. So basically, when we have the articular-sided tears, there is a capsular involvement first, then also tendon involvement, but remember that we have a capsular layer here as well, not just at the level of the subscapularis. In terms of characterization of the superior complex, remember that the amount of tendon fibers changes depending on the location. It will be maximal anteriorly, and then the fibers of the tendon diverge going posteriorly to merge with the infraspinatus, but they will be less and less going posteriorly, and so at the end the superior complex will become thinner and thinner, and probably at the end we'll have just capsule, no more supraspinatus. When we scan deep to the infraspinatus, we continue to see these fibers. Of course, there may be some fibers coming from the supraspinatus, but they may extend posteriorly up to 1 centimeter, not more posteriorly than 1 centimeter from the tendon position. And so, when we place the probe in the long axis of the infraspinatus, this is the posterior glenoid, this is the tendon. Look at this video clip. What is that? Is the tendon? No, it's the capsule. Again. And this capsule form the deep layer of the infraspinatus, in this case, an image that is more similar to the one of the subscapularis. So, just to show so when we go to scan the external rotators, this is the long axis image of the tendon of the infraspinatus we have to reduce the magnification a bit to increase the gain. In the deep part, I need to see the posterior labrum. And then when we rotate the arm internally and externally, we see a kind of tissue, a hyperechogenic layer located here. And this layer doesn't belong to the infraspinatus, it reflects the capsule and is in continuity with the image of the labrum. Then you see now it's very redundant here, no more fibrillar. It becomes more echogenic in internal rotation, but is a separate structure compared to the tendon of the infraspinatus. Remember, when you wanted to have a good image of the infraspinatus, this is not written in the guidelines. No, this is a very nice position of the arm, because you place the probe here, and you are in a perfect alignment over the infraspinatus tendon. So this is the long axis image of the infraspinatus. I feel that this position is much more productive to image the infraspinatus. Again, what is that? Is the capsule. And what is the deep layer visible here? Probably is the capsule, and the capsule will merge with the fibers closer to the insertion. This is the insertion of the tendon, and even posteriorly you can see two definite layers of fibers. So this is what happens. The supraspinatus, the infraspinatus, they converge, but they remain separate structures proximally. And at the end, the two tendons were displaced by the anatomist. You see the joint capsule distally. So the insertion is distal, and probably in a distal position is impossible to dissect the two tendons from the capsule. But anyway, ultrasound is able to see some differences. And when you scan remember, when you scan the infraspinatum using the Middleton position, the Middleton position is not adequate for the infraspinatus. But when you go towards posteriorly, and you move to at the level of the infraspinatus tendon, you should rotate the probe like this, to be in the axis of the infraspinatus. In this case, you can demonstrate the tendon of the infraspinatus, and you can separate this tendon from the superior complex. Okay, so fishes again. Now we are in the aquarium of ECR 2019 again. Thank you very much for your attention.